Ever get that feeling like, is this the big moment? Like you're waiting for something huge, but you just aren't sure if it's really happening.
Oh, yeah, definitely.
That's Kathy and Chuck right now, heading to the birthing center, all set to go. But the big question is it actually the real deal or not?
It happens all the time.
That uncertainty, figuring out those early signs of labor, it's a pretty universal experience, right?
Yeah, it really is. And you know what's so interesting is even with all we know about labor and delivery,
Right.
figuring out that exact start time, it's still a bit of a mystery. There's a lot going on that we don't fully understand.
So much complexity, and that's exactly what we're diving into today.
Yeah.
The whole process of labor and birth. We've got some seriously in-depth info here, the kind of stuff that's gold for student nurses and faculty.
Absolutely.
But we want to make sure we're giving you the core insights, the stuff you really need to know to get a clear picture of this incredible journey.
You do it in a way that's super useful too, right? We're hitting the key points without overwhelming anyone.
Yeah, exactly. So let's start at the very beginning. What actually flips the switch and says, okay, time for labor to start?
Well, like we said, the precise trigger is still being researched,
Sure.
but there are some major players we know are involved. It's like a whole team effort inside the body.
Right.
One of the first things is that physical stretching of the uterus as the baby grows and there's more amniotic fluid.
Okay.
It's like the uterus is saying, hey, things are getting a little crowded in here.
That makes sense. A physical cue that things are maxed out.
Exactly. And then you've got the hormonal shifts, that whole dance between progesterone and estrogen.
Okay.
The main theory is that as we get closer to the due date, progesterone starts to decrease while estrogen takes the lead.
So what's the impact of that? What does that shift actually do?
What's really cool is how it affects the muscle cells of the uterus, the myometrium.
Okay.
It leads to more gap junctions. These are like little doorways or communication channels between those muscle cells. And having more of them means better coordination, which is key for those synchronized contractions that define labor.
So the uterus is getting its communication network all set up.
Exactly. It's getting ready for the big job ahead.
And estrogen, it makes the uterus more sensitive to oxytocin, right?
Yes, exactly. Oxytocin, the love hormone, but also a major player in labor.
Right, of course.
As the pregnancy progresses, the uterus becomes way more responsive to those oxytocin signals, so contractions are more likely.
So it's primed and ready to go. And it's not just the mom's oxytocin, the baby's involved too, right?
Absolutely. As the baby gets closer to full term, their adrenal glands start pumping out more cortisol, and this fetal cortisol, along with those rising maternal oxytocin levels, they work together to stimulate the production of prostaglandins.
Prostaglandins. We hear that term a lot with labor. What do they do?
Prostaglandins are like the local messengers that get things moving. They contribute to even more uterine contractions, and really importantly, they help that cervix soften up and become more flexible. They also team up with oxytocin to boost those gap junctions we talked about, making the myometrium even more responsive.
Okay.
So it's this whole chain reaction, hormonal changes, making the uterus more sensitive, and then mom and baby both triggering the release of these signaling molecules that ultimately lead to the cervix opening and those powerful contractions that will eventually help move that baby through the birth canal.
Wow, that's a lot of steps.
Remember, those contractions have two main jobs, dilating the cervix and pushing the baby out.
Okay, so we've got the initiation, the behind-the-scenes setup, but what about the signs that tell a pregnant person, hey, labor might be right around the corner? We hear about all sorts of things happening in the days and weeks leading up to it.
Yeah, those are the premonitory signs. And the big thing to remember is that they can be totally different for every woman. Not everyone experiences all of them, and the timing can vary even between pregnancies for the same person. Let's start with the cervix itself during pregnancy. It's been firm and closed, a protective barrier, but now it needs to make some big changes to get ready for birth.
It's got to soften and open up.
Exactly. And this softening, we call it cervical ripening, can start weeks or even just hours before labor actually kicks in.
Wow, okay.
Along with softening, the cervix might even start to dilate a little, and the baby's head could move further down into the pelvis.
Okay.
What's happening at a cellular level is pretty interesting. Those prostaglandins we talked about are at work again, along with Braxton Hicks contractions, those practice contractions, helping to make some enzymatic changes in the collagen fibers of the cervix.
Okay.
This makes it softer and more stretchy, which is essential for effacement, the thinning of the cervix, and dilation, the opening.
Okay, so that's the internal prep work. What about the external signs, the ones you actually notice? I know lightening is one. What does that mean exactly?
Lightening is a great term for it. It describes what a woman feels when the baby's presenting part. Usually the head in a head-down position drops lower into the true pelvis. And as this happens, the uterus itself lowers and moves forward a bit.
So things feel less crowded up top.
Exactly. Women often say their breathing gets easier, less pressure on their diaphragm. They might have less heartburn or reflux too.
Okay.
But this descent comes with its own sensations. You might hear about increased pelvic pressure leg cramps, swelling in the lower legs, and low back discomfort.
Right.
And because there's more pressure on the bladder, there can be more frequent urination and maybe more vaginal discharge.
Makes sense.
It's interesting that for first-time moms, lightning can happen weeks before labor starts, but for moms who've had babies before, it might not happen until labor's already going.
So the body knows the drill the second time around.
Right, exactly.
Another thing we hear about is nesting that burst of energy. Is that a real thing?
Absolutely. Many women report this sudden surge of energy, usually a day or two before labor starts.
Wow.
And you're right, it's often focused on getting everything ready for the baby cleaning, organizing, prepping the nursery. We think it might be tied to a temporary increase in epinephrine, possibly triggered by that dip in progesterone we talked about earlier.
So it's like a final adrenaline boost to make sure everything's perfect for the baby.
Exactly.
What about bloody show? That one sounds a little scary.
It does sound a bit alarming, but it's usually a normal sign that labor's on its way.
Okay.
See, during pregnancy, the cervical canal is sealed off by a thick mucus plug that helps protect the uterus from infection. As the cervix starts to soften and dilate, and as there's more pressure from the baby, this mucus plug can get pushed out.
Okay.
And when that happens, tiny blood vessels in the cervix can rupture that little bit of blood, mixes with the mucus, and you get those pink-tinged secretions, the bloody show.
Okay, that's good to know. It's usually not a reason to panic.
Right.
We've also mentioned Braxton Hicks contractions. How do those change as labor gets closer?
They can definitely become more noticeable, maybe even pretty strong, those practice contractions that happen throughout pregnancy. As you get closer to labor, they might come more often and feel more intense, but they usually stay irregular.
Yeah.
They're often felt as a tightening in the upper uterus, the abdomen, sometimes even into the groin, and then they ease up.
Interesting.
A key difference from real labor contractions is that they're usually felt more in the front, while true labor contractions are more in the lower back and radiate forward.
So location matters.
Yes,
Yeah.
exactly. Braxton Hicks are thought to help get that cervix into a more anterior position and soften it up, ready for the main event.
Okay.
The big difference from true labor is that they're irregular. They don't follow a set pattern, and they often go away or get less intense if you change what you're doing, like walk around or empty your bladder or even just switch positions. They usually last about 30 seconds, but can sometimes go up to 2 minutes.
Okay.
We always say if these contractions last more than 30 seconds and happen more than 4 to 6 times an hour, especially before 38 weeks, it's time to call the healthcare provider just to rule out preterm labor.
That's super clear guidance. And then there's that classic water-breaking moment, the spontaneous rupture of membranes.
Yeah, that's the one everyone pictures.
Right.
And it is a big sign that labor is starting. We call it pre-labor rupture of membranes, or PROM, if it happens before regular contractions begin.
Okay.
It happens in a good number of term pregnancies, and for most of those women, labor will start on its own within 24 hours.
Okay.
It can feel like a sudden gush or a slow trickle because even after the initial break, the body keeps making amniotic fluid to protect the baby,
Right.
but that's when you need to call your doctor.
What are the main concerns once those membranes have ruptured?
The big things are infection risk and the potential for the umbilical cord to prolapse once that amniotic sac is open. There's no longer that protective barrier against infection.
Right.
And if the baby's not fully engaged in the pelvis when that fluid rushes out, there's a slight risk the umbilical cord could slip down in front of the baby, which could cut off oxygen. That's why it's crucial to contact your healthcare provider right away if your water breaks so they can check everything out and monitor for any complications.
Makes sense. That story in our source material about the woman in the grocery store when her water broke really highlights that.
Oh, yeah, definitely.
Dealing with that unexpectedly and then having those potential risks, it shows why you need medical help right away.
Absolutely. Knowing the signs and when to call for help is so important.
So with all these potential signs, how can you tell the difference between a false alarm and real labor? That's what Kathy and Chuck were trying to figure out.
That's the million-dollar question, right? Figuring out false labor versus true labor is a big part of understanding the whole birthing process.
For sure.
False labor, sometimes called Prodromal labor, or just strong Braxton Hicks contractions, involves contractions that aren't regular and don't change the cervix much.
Okay.
True labor, on the other hand, has contractions that come at regular intervals, getting more frequent, longer, and stronger.
Right.
And most importantly, they cause the cervix to dilate and a face thin and open up.
We have a table in our material that sums up those key differences. Contraction timing is a big one, isn't it?
Absolutely. In true labor, those contractions get into a rhythm. The time between them gets shorter and shorter. They often settle into a predictable pattern, like every 4 to 6 minutes, lasting 30 to 60 seconds.
Okay.
False labor contractions are all over the place. No consistent pattern. You might have long gaps or short gaps between them.
So it's about looking for that consistency.
Yes, exactly.
And what about how strong the contractions are?
True labor contractions, they get stronger as labor goes on. You'll feel more pressure, especially in the lower abdomen and maybe radiating to your back and down.
Okay.
False labor contractions, they're often weak and don't really build in strength.
Yep.
You might have one that feels a bit stronger and then a bunch of weaker ones.
Got it. And where you feel the discomfort, that's important too, isn't it?
Yeah, true labor discomfort, it usually starts in the lower back and then wraps around to the front of your belly. Lots of women describe it as a tightening or cramping that goes all the way around. False labor is more likely to be just in the front.
That's helpful to know, and this is a really practical tip. What happens when you change what you're doing?
Oh, yeah. That can be really telling. True labor contractions, they keep going no matter what. You do lie down, walk around, change positions, they're there.
Okay.
But with false labor, those contractions might actually stop or at least ease up a lot when you walk or move around.
So our material talks about when to stay home and when to head to the hospital.
Yeah.
It basically says stay home if it's false labor. Try drinking fluids walking around. If the contractions don't get stronger or if they ease up, it's probably not the real deal.
Right.
But if it's true labor, usually the advice is to go in when contractions are about 5 minutes apart, lasting 35 to 60 seconds, and strong enough that you can't really talk through them.
That's the typical advice, and it's so important to talk about the anxiety that comes with potentially being sent home.
Oh.
It's common, and it can be frustrating, but we should try to help women see those early, less intense contractions as their body getting ready for the main event.
It's like a warm-up.
Exactly. Early labor, especially for first-time moms, can be a long, gradual process.
Right.
Remember, it can sometimes take up to 20 hours for that cervix to fully dilate in a first pregnancy.
That's a long time.
It is.
Thinking back to Kathy and Chuck when her contractions turned out to be false labor, what kind of explanation should they have gotten to help them understand what was happening and what to expect?
They should have gotten clear and empathetic information about what false labor is like, those irregular contractions, no real cervical change if they checked that, and that they'd likely go away with rest or a change in activity.
Okay.
They should have also been told what true labor might feel like, that regular pattern of contractions getting stronger, closer together, and clear instructions on when to come back to the birthing center or call their doctor.
So being prepared.
Exactly. And using reassuring language, calling those early contractions preparation, can really help reduce anxiety and set realistic expectations.
That makes a lot of sense. Now, let's shift gears a bit and talk about all the things that can affect how labor progresses. We've got the 10 Ps of labor laid out in our material.
Oh, yes, the 10 Ps.
We've got the classic 5 passageway, passenger powers, position, and psychological response.
Right.
But then we've got 5 more that really focus on the woman's experience and what she wants. Philosophy, partners, patience, patient preparation, and pain management. It's like labor is this huge puzzle with all these pieces.
It really is. And those extra 5 Ps, they show how important the woman's own experience is, her beliefs, her support system, her choices. All these things play a role in labor and birth.
So it's not just a physical event, it's mental and emotional too.
Exactly.
Let's start with the passageway, the birth canal. What's important to know about this one?
Well, human childbirth, it's actually pretty tough compared to a lot of other mammals.
Really?
Mostly because of how big the baby's head is compared to the mom's pelvis. The passageway has 2 main parts: the bony pelvis and the soft tissues. The bony pelvis is super important because it's the fixed structure that the baby has to pass through.
Right.
Healthcare providers, they often check out the mom's pelvis during prenatal care to see if there are any bony issues that could affect labor.
Makes sense.
As pregnancy goes on, hormones like relaxin and estrogen, they soften up those ligaments and connective tissues in the pelvic joints,
Okay.
which gives a little more wiggle room.
So the pelvis is literally changing to make space.
That's right.
And we talk about the true pelvis and the false pelvis. The true pelvis is the one that really matters for birth.
Right, exactly. The false pelvis is higher up above that imaginary line called the linea terminalis. It mainly supports the growing uterus.
Okay.
The true pelvis, that's the bony channel the baby has to move through during birth. We describe it as having three parts: the inlet, the mid-pelvis, and the outlet.
Okay.
The inlet is the top opening widest from side to side. The mid-pelvis is curved and often the narrowest part. It's also where pressure on the baby's chest helps squeeze fluid out of their lungs.
Interesting.
And the outlet is the bottom opening widest from front to back.
So it's like a winding path with different challenges.
Exactly.
I remember reading about specific pelvic measurements. Why are those so important?
Those measurements help us figure out how big the true pelvis is and whether there's enough room for a vaginal birth.
Makes sense.
Key ones are the diagonal conjugate, the transverse diameter of the outlet, and the true or obstetric conjugate. If these measurements are within a certain range, it suggests there's enough space for the baby to pass through.
Okay, so it's about making sure things will fit.
Yes, and then there's pelvic shape. I didn't realize there were different types and that they could affect labor.
Oh, yeah, tell me about that.
So there are four main shapes: gynecoid, anthropoid, android, and platypelloid. The gynecoid pelvis is the classic female pelvis, and it's the best for vaginal birth because of its rounded inlet, and roomy outlet makes it easier for the baby to rotate and descend.
Okay.
The anthropoid pelvis has an oval inlet and a deep cavity. It's usually better than the android or platypelloid types.
Okay.
The android pelvis is more heart-shaped, like a typical male pelvis, and it often means a tougher labor with potential problems with descent and rotation.
Mm-hmm.
And the platypelloid pelvis, it's flat and shallow, which can make it hard for the baby to even enter the pelvis.
So not ideal.
No, not usually.
But most women don't have a perfectly textbook pelvis.
That's right. Most are a mix of these shapes. And whether vaginal birth is possible really depends on the baby's size and position compared to that woman's unique pelvis.
So it's all about how things line up.
Yes, and the baby's skull can mold a bit too, which helps. And the baby can adjust its position to fit the widest parts of the pelvis.
That's amazing. The body is so adaptable.
It really is.
We can't forget about those soft tissues, either the cervix, the pelvic floor muscles, and the vagina.
Oh, they're essential. The cervix has to efface, thin out, and dilate, open up to let the baby into the vagina. The pelvic floor muscles, they help the baby rotate as it moves down. And the vagina, it's incredibly stretchy. It expands to let the baby through.
Okay, so a lot going on there.
Definitely.
Moving on to the second P, the passenger that's all about the baby and the placenta.
Right, lots of factors on the baby's side that can affect labor.
Yeah. What are the key ones?
Well, you've got the size of the baby's head and how well it can mold.
Okay.
The baby's attitude, whether they're flexed or extended. The fetal lie, how the baby's spine is lined up with the mom's. The fetal presentation, which part of the baby is coming first. The fetal position, how that presenting part is related to the mom's pelvis. The fetal station, how far down the baby is and whether engagement has happened. That's when the widest part of the baby has entered the pelvis.
Wow, that's a lot to consider.
It is, but it's all about understanding how the baby is positioned and how that affects labor.
Let's start with that fetal head. I know the fact that those skull bones aren't fused yet is really important.
Super important. Unlike an adult skull, the baby's skull has these flexible fibrous sutures connecting the bones.
Right.
And where those sutures meet, you've got the fontanelles, the soft spots. These sutures allow the bones to overlap a bit when there's pressure from contractions and as the baby moves through the birth canal.
So it's like the skull can reshape itself.
Exactly. We call it molding. It can temporarily make the baby's head a bit smaller so it can get through the pelvis.
That's fascinating.
Sometimes after birth, you might see some temporary swelling on the baby's head called caput succedaneum, or a collection of blood called a cephalohematoma.
Okay.
But these are usually harmless and go away pretty quickly.
Good to know. And those sutures and fontanelles, they're landmarks for healthcare providers too, aren't they?
Absolutely. By feeling those during a vaginal exam, they can tell how the baby's positioned in the pelvis and how much the head has rotated.
So it's like a map.
Exactly. The anterior fontanelle, it's diamond-shaped and stays open for a while after birth to allow for brain growth. The posterior fontanelle is triangular and closes up sooner.
Interesting.
We also look at key diameters of the baby's skull, like the suboccipito-bregmatic diameter, that's the smallest front-to-back diameter, and the ideal one in a vertex presentation.
Okay.
And the biparietal diameter, the largest side-to-side diameter. The best way for the baby's head to be positioned is with the chin tucked to the chest. That gives us the smallest diameters to work with.
Got it. So it's all about how things line up.
Exactly.
What about fetal attitude?
Fetal attitude is all about the baby's posture, how flexed or extended they are.
Okay.
The best attitude for birth is full flexion, back rounded, chin tucked thighs flexed on the belly legs, bent at the knees.
Makes sense. A nice compact position.
Right. That gives us the smallest head diameter. Anything else, like the head being extended, can make things trickier.
Got it. And fetal lie. That's how the baby's lying in the uterus, right?
Yes. Fetal lie is how the baby's spine is positioned compared to the mom's spine. The most common is longitudinal, where they're parallel.
Okay.
Then you've got transverse, where they're perpendicular, and oblique, somewhere in between. Oblique is often temporary and will usually become longitudinal or transverse.
Okay.
But a transverse or oblique lie that doesn't change, that usually means a cesarean.
Got it. And fetal presentation. That's which part of the baby is leading the way.
Exactly what's coming first into the pelvis.
Yep.
There are 3 main presentations: cephalic, head first, breech, buttocks, or feet first and shoulder.
Okay.
Cephalic is the most common by far. At term breech can be tricky because the biggest part, the head, comes last and could get stuck.
Okay.
There's also a higher risk of the umbilical cord getting compressed, and breech babies aren't as good at dilating the cervix as head-down babies.
Okay.
Within cephalic, there are variations depending on how flexed the head is, vertex, military brow, and face breech has frank complete and footling or incomplete depending on the position of the legs and feet.
So breech is like a whole category.
Yeah, it is.
What about shoulder presentation?
That's when the baby's lying sideways and the shoulder's trying to come first. You often see what's called the turtle sign, where the head comes out a bit and then goes back in.
Oh, wow.
That usually means a cesarean.
Got it. So it's all about how the baby's positioned.
Exactly.
And then there's fetal position, that 3-letter code.
Yeah, that one can be a bit confusing.
Yeah.
It tells you which way the presenting part of the baby is facing in relation to the mom's pelvis.
Okay.
The first letter is L for left or R for right.
Yeah.
The second is O for occiput in a vertex presentation. S for sacrum in a breech presentation. M for mentum or chin in a face presentation. And A for acromion or scapula in a shoulder presentation. Sometimes D for dorsum in a shoulder presentation too.
Okay.
And the third letter is A for anterior or P for posterior. So LOA means the back of the baby's head is pointing towards the mom's left front side. LOA and ROA, right occiput anterior, are the most common and usually the easiest positions for birth. An occiput posterior or OP position can sometimes mean a longer, tougher labor, and some positions just won't work for vaginal delivery.
So position is key.
It is.
What about fetal station that tells us how far down the baby is?
Exactly. It describes where the baby is in relation to the ischial spines, those bony landmarks in the middle of the pelvis.
Okay.
Minus stations mean the baby's higher up. Plus stations mean they're lower down. It's like tracking their progress down the birth canal.
Like they're getting closer to the finish line.
Exactly.
And finally, engagement.
Engagement is when the widest part of the baby, usually the head in a head-down presentation, has passed through the top of the pelvis.
Okay.
For first-time moms, this can happen weeks before labor. But for moms who've given birth before, it often happens during early labor. If the baby's still movable above the pelvis, we say it's floating.
Got it. So lots to consider with the passenger.
Definitely.
Now let's move on to that third E. P powers the contractions and the pushing.
Right. The main power comes from those uterine contractions, those involuntary rhythmic muscle squeezes that happen throughout labor.
Okay.
It's important that they're intermittent with breaks in between.
Why is that?
Because those breaks allow the uterus and placenta to get a rest and for blood flow to return, making sure the baby keeps getting oxygen.
Oh, that makes sense.
Those contractions are what cause the cervix to efface, thin out, and dilate open during the first stage of labor. And then in the second stage, they team up with the moms pushing to get the baby out.
It's teamwork.
It is.
So effacement is when the cervix goes from about an inch thick to paper thin.
Yeah, and we describe it as a percentage from 0 to 100.
Okay.
Dilation is the opening measured in centimeters from 0 close to 10, fully dilated.
Right.
For first-timers, effacement usually happens before dilation, but for moms who've had vaginal births before, they can happen together.
The body's efficient the second time around.
Exactly.
So tell me about those contractions in early labor.
In early labor, they're usually mild, lasting about 30 seconds and coming every 5 to 7 minutes. As labor progresses, they get longer, up to a minute, more frequent every 2 to 3 minutes, and stronger. We call them moderate to strong.
Got it.
Each contraction has 3 phases. The increment when it builds up the acme, the peak, and the decrement when it eases off.
Okay.
We keep track of them by their frequency, how often they come, duration, how long they last, and intensity, how strong they are.
Right. And how do you measure intensity?
You can feel the abdomen to get a sense of it.
Okay.
Or use an internal monitor called an intrauterine pressure catheter. But that's not routine in low-risk labors because it can increase the risk of infection or injury.
Safety first.
Always.
And then there's the pushing that's the secondary power, right?
Exactly. The mom's voluntary pushing that we call bearing down helps those contractions get the baby out in the second stage.
So important to work with your body.
Absolutely. And timing that pushing with the contractions is key so you don't waste energy. Things like an epidural anxiety or just being exhausted can make it harder to feel that urge to push and to push effectively.
That makes sense.
Yeah.
Now let's talk about the mom's position during labor and birth. I know that's changed a lot over time.
It really has. Historically, women gave birth in all sorts of upright positions, sitting, squatting, kneeling, standing.
Right.
Those positions use gravity to help the baby descend, and they can make the pelvis a bit bigger.
Okay.
But as modern obstetrics developed, especially in Western medicine, lying on your back became the norm in hospitals.
Interesting. Why is that?
Some people think it's because of the increased use of forceps, the fact that more male doctors were delivering babies and that those positions were just easier for doctors, especially after anesthesia became common.
So it's like a combination of factors.
Yeah, but now we know that lying on your back for a long time might not be the best for labor and the mom's well-being.
Really?
Yeah, upright and side-lying positions have some advantages.
Like what?
Well, gravity can help the baby come down easier in upright positions, and not lying flat on your back reduces the risk of the uterus compressing a major blood vessel, which could affect blood flow to the baby.
That's a big deal.
It is, but even with that knowledge, lots of women still spend a lot of labor in bed, often on their backs.
Why is that?
It could be that they think it saves energy, or that it's easier for monitoring the baby, or that's what their doctor prefers.
What?
Or it could be that it makes vaginal exams and adjusting those monitor belts simpler, or just because the bed is the main piece of furniture in the room.
So a lot of reasons. It sounds like encouraging women to move around and find comfy positions is really important. What about those peanut balls? I've heard about those.
Peanut balls, they're great. They're those peanut-shaped exercise balls that you put between a woman's legs while she's lying down, usually on her side.
Okay.
Studies show they can actually shorten labor and make vaginal birth more likely, even for women with epidurals.
Really?
It's a simple thing that can really help the baby get into a better position.
That's amazing.
It is. And having other options like birthing balls, squat bars, and pillows can also help women find positions that feel good and help labor progress.
So it's about giving women choices. What are the main benefits of those upright and side-lying positions compared to lying on your back?
They've been linked to shorter labor, less need for interventions like vacuum or forceps, fewer episiotomies and tears, fewer issues with the baby's heart rate, more comfort for the mom, less need for pain meds, and a better sense of control for the woman.
Wow, that's a long list.
It is even nice, the National Institute for Health and Care Excellence, they recommend against lying flat on your back because of the increased risks of longer labor, cesarean birth, more pain, and problems with the baby's heart rate.
So there's strong evidence to support those more upright positions.
Absolutely.
Okay, let's talk about that fifth P, psychological response, the mom's mental and emotional state that must play a huge role in labor.
It's absolutely crucial. Childbirth is a major life event. It can affect a woman's confidence, her relationships, her whole emotional well-being.
Right.
How she feels during labor can affect her ability to handle the pain, the progress of labor itself, and how happy she is with the experience overall.
Makes sense.
There are a few things that can help make it a positive experience.
Like what?
Having clear, accurate information about labor and birth, feeling supported, and not alone having a sense of control, trusting the healthcare providers, feeling good about the pregnancy, being able to control her breathing or comfort measures, having good preparation for childbirth, and having a strong sense of self and a good support network.
So feeling informed, empowered, and supported.
Exactly. Feeling safe and secure can help women feel more in control and handle the intensity of labor better. On the flip side, anxiety and fear can release stress hormones that can actually mess with blood flow to the uterus and placenta.
Oh, wow.
That's why relaxation techniques and a calm mindset are so helpful. They can support the natural processes of labor, preparing yourself mentally and emotionally to work with those contractions, not against them. That's really important.
It's like a mind-body connection.
Exactly.
Now let's move on to those extra 5 Ps that really focus on the woman's perspective. The first one is philosophy.
Philosophy is all about the different ways of looking at childbirth. Some people see it as a medical event that might need interventions. Others see it as a normal process that can happen safely with support and minimal medical